Hello everyone, welcome to this webinar on recent advances in the pharmacotherapy of diabetic retinopathy with a focus on PPAR alpha agonism. My name is Michel Hermans. I am a diabetologist working here at St. Luke's University Hospital in Brussels. And it's my pleasure to introduce our speaker today, who is Professor Alberto Zambon. Many of you know him already. He's an associate professor of medicine at the University of Padova in northern Italy, and he's also an assistant professor of medicine at the University of Washington in Seattle, USA. Many of you know him already, and he has done a lot of research on the pathogenesis of atherosclerosis, especially on the mechanism of plaque progression and regression, as well as on the genetic background leading to lipid and lipoprotein abnormalities, and also on new therapeutic options modulating atherosclerosis. He has been awarded many prizes and awards, including from the American Heart Association, from the American Society of Clinical Investigation, and also of the American Federation for Aging Research and the Merck Young Investigator, and many others. And also is a member of the International Steering Committee of the Residual Risk Reduction Initiative. So it's a pleasure to introduce him, and Alberto, the floor is yours for this talk.
Thank you, Michel, for your very, very kind introduction. It's a great pleasure to welcome all of you, dear colleagues, to this webinar, who has as a topic diabetic retinopathy, type 2 diabetes, of course, and recent advances in therapy with a specific focus on PPAR alpha agonists. As Michel Hermans said, I'm a professor of medicine at the University of Padua, Department of Medicine, by training endocrinologist with a specific interest in lipids. If we can have the first slide, please. So these are my faculty disclosures. We're talking about patients with diabetes and particular microvascular complications. So let me start by setting the clinical background of diabetic retinopathy. The number of patients with diabetes is increasing worldwide. Currently, 537 million people are affected with diabetes. By, let's say, 2041, that number is expected to be almost 784 million. And if you look at the different regions in the world, it's increasing everywhere, particularly Africa and the Middle East, the MENA region. This is very important because right now, about 93 million people suffered from eye damage with diabetes, of course, and that number is bound to increase. Within 20 years of diagnosis, more than 3 out of 5 patients with type 2 diabetes will develop diabetic eye disease. Approximately 1 out of 3 patients with diabetes will develop a retinopathy. And of these patients, 1 out of 3 will develop a vision-threatening diabetic retinopathy. So it is crucial to understand the pathophysiology and the clinical evolution of diabetic retinopathy, given the pandemic of the disease, to understand when and how we can fight and prevent progression of this microvascular complication. Diabetic retinopathy is a microvascular disorder which affects capillaries inside the retina that become damaged mainly due to chronic hyperglycemia. Chronic hyperglycemia predisposes the capillaries in the retina to other insults and injuries, for example, those related to systemic hypertension. Retinopathy is a progressive disease that can lead to severe vision impairment and, in end-stage, blindness. It's one of the main causes of blindness in the world. There are 3 main steps in diabetic retinopathy: non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, and diabetic macular edema. If we look progressively at the anatomical changes, the mild non-proliferative diabetic retinopathy is characterized by the presence of microaneurysms in the retina, Other alteration called intraretinal microvascular abnormalities are present together with microaneurysms in the moderate stage. In the severe stage of non-proliferative retinopathy, we have intraretinal hemorrhages, microaneurysms that are both observed. Proliferative diabetic retinopathy is associated with macular edema, hard exudate, and the threatening retinal neovascularization. Keep that in mind because neovascularization is a key word that will come back later on in the presentation when we talk about PPAR alpha agonists. Now, when we look at basic mechanisms from a pathophysiological standpoint, both hypertension and hyperglycemia lead to vascular dysfunction. Particularly, hyperglycemia leads to a number of biochemical and molecular changes, including advanced glycation end product, inflammation, polyol pathways, that results in hypoxia, results in oxidative stress and inflammation. The endothelial cells and the pericytes of the retina actually exposed to these oxidative stress, hypoxia, and inflammation produce cytokines and chemokines, including vascular endothelial growth factor, interleukin-6, MCP1. I mean, these molecules at the end of the day will lead to pericyte and endothelial loss, so damage to the vascular wall, thickening of the basement of the membrane, and leukocytosis. These are key changes in the progression of diabetic retinopathy. From an anatomical standpoint, this slide tells you what's happening in the retina. Actually, microvascular changes, as I showed you in the previous slides, lead to leakage. So there is a blood-retina barrier breakdown. The leakage leads to macular edema, and the macular edema, if progresses, leads to vision loss. There is also another mechanism by which microvascular changes can insult the retinal vessel, and that is hypoxia. Hypoxia needs or results in the production by a number of cells to VGF, vascular endothelial growth factor, which leads to neovascularization and progressive loss of visual acuity. So these are two main mechanisms by which diabetes through leakage and hypoxia can lead to progressive diabetic retinopathy. Now, what are the approaches that are currently used to prevent or slow down progression of diabetic retinopathy? Well, as I told you, diabetic retinopathy is one of the microvascular complications that affect the patients with diabetes. Diabetic nephropathy is the other one, and neuropathy is the third one. They are both compromising in a significant way the quality of life of our patients with diabetes, whereas macrovascular complication, specifically myocardial infarction, is compromising lifespan and life expectancy of our patients with diabetes. So they live a shorter lives if they're not properly controlled because of macrovascular complication. They live worse life. The quality of life is not as good as people without diabetes because of microvascular disease. Optimal blood glucose control represents the mainstay together with optimal blood pressure control. There are a number of trials suggesting that optimal glucose control is specifically effective in microvascular disease. But this slide suggests that it's a multifactorial approach that is the winning approach in this case to prevent retinopathy. We're going to focus again on retinopathy, and I'm focusing specifically on a longer follow-up of a famous study called STENO2. This is a 13-year follow-up. In the STENO2 trials, our colleagues approached patients with diabetes in two ways: a conventional approach and an intensive treatment. Intensive treatment meant oral anti-diabetic therapy, anti-hypertensive therapy with ACE inhibitors, lipid-lowering agent, statins, plus a very tight and effective diet and lifestyle program. Now, after a mean of 13 years, what you see here is that although HbA1c by current standards, it We cannot say it's properly controlled. We can do better than 7.7%, and we can do better in terms of systolic blood pressure than 140 millimeters of mercury. But in terms of diastolic blood pressure, the levels reached is pretty good, 74. LDL cholesterol, remember that at that time, patients at the very high risk at the 70 milligrams or 1.8 millimoles has a goal for their cardiovascular risk. HDL was pretty good, triglyceride was pretty normal. Despite this multifactorial approach, patients with an intensive treatment indeed had a significant, this is 43% decrease as compared to those on conventional treatment, decrease in progression of diabetic retinopathy, if you look at the two bars on the far right of the slide. But still, we had a significant progression, more than 50%, 51% progression of diabetic retinopathy, despite the multifactorial control. So it's proper to say that we have a residual macrovascular risk, but we also have, and we can talk about, a residual microvascular risk, in this case, residual risk of retinopathy, despite the multifactorial control. So let's focus our attention on the new tricks. By saying new tricks as compared to old dogs, I mean PPAR alpha agonist. And PPAR alpha agonist, let's look at the biological mechanisms, are actually new compounds, actually not new, I must say, because they've been here and present before statin therapy, the old fibrates. They are compounds that binds to nuclear receptor. The natural ligands, of course, are fatty acid, but fibrates, glitazones, glitazars, they bind to receptors inside the nucleus. They require cofactors, and the specific function is, once, for example, fibrates bind to the PPAR alpha receptors family, there are a number of receptors in the PPAR alpha activator receptor, in the PPAR nuclear receptor PPARs, PPAR alpha, PPAR gamma, PPAR delta. So the PPAR alpha are the ones that we're interested when we talk about fibrates. When they bind to cofactors, they bind also to specific region called PPAR responsive element in target genes, where they activate and promote the synthesis of specific molecules. For example, molecules that deals with lipid metabolism, lipoprotein lipase, some apolipoproteins, glucose homeostasis as well. They can also bind to other sections of genes where they can repress, inhibits synthesis of certain molecules, particularly molecules that have to do with the inflammatory pathway. So it's a very interesting class of molecules where the effect is actually carried out inside the nuclei by either activating genes or repressing other genes. So it's a very sophisticated way of working if you think as compared to statins. Now, there are old evidence, and by old I mean 1965, 1977, that fibrates prevent retinal exudation and angiogenesis. At that time, we used to try clofibrate, that is not on the market anymore. In the late 60s, early 70s, we did not know what kind of meaning had that effect on retina. So, but we have data, very old data, suggesting a direct effect on diabetic retinopathy by fibrates. We forgot about those data. So let me show you how now new evidence strongly support an effect of PPAR activation by phenofibrate and pimafibrate, are the two fibrates that we'll be dealing with today, on forms of retinopathy, particularly diabetic retinopathy, with an effect on key steps leading to progression, development, and progression of these microvascular complications, particularly inflammation, apoptosis and cell death, and new vascularization, by, of course, inhibiting certain steps of these pathophysiological actually chain. So when we look at the effect of fibrates, and particularly in this case, pimafibrate, this is a very recent evidence. As you can see, the paper was published in 2023. And these papers, it's in animal models, in a mouse model, show that pimafibrate can prevent new vascularization and macular degeneration. What they did, they took mice Mice were orally administered pimafibrates 4 days before laser irradiation. Now, these are representative images by using a specific staining, and the quantitative analysis is seen here on the far right. And as you can see here, the presence of pimafibrate is the bottom picture, clearly reduce that red area that tell you the size of neovascularization after laser injury in this mouse model. So pimafibrate, and from a quantitative standpoint, that is clearly a significant reduction if you see the graph on the far right. So medication or pre-medication with pimafibrate, oral pimafibrate, actually led to a significant decrease in neovascularization after laser injury in this retina in mouse model. Now, as you can see here from the image at the bottom, they use microglia. Microglia might be involved in both inflammations and neovascularization signal pathway in the retina of this animal. And now, by a specific staining, you can see that 7 days after laser irradiation, so the sham is the first picture on the left. The central picture is the microglia stained without pimafibrate on the retina of these guys. And in the retina of these animal models with pimafibrate is the picture on the far right. So clearly there is a decrease in the staining, suggesting that a decrease in the microglia activation, and the preventive effect of pimafibrate on neovascularization formation could be in fact explained by inhibition of activated microglia, as you see on the picture on the far right. So there is less neovascularization. Probably one of the mechanisms leading to this prevention of neovascularization is inhibition of activated microglia, as you can see on the bottom series of picture, far right. Now, let me show you another recent study, the results actually, again in mouse models. And this is a different model. It's an ischemia reperfusion model, which is a model that is commonly used in experimental animal models to examine the preventive effect of certain compounds, in this case PPAR alpha agonist, specifically pimafibrate, against retinal degeneration. Now, as you can see here on the panel, again, there is no ischemia reperfusion on the picture of the retina on the far left. Now, ischemia reperfusion without pimafibrate administration on the right. These are representative images that clearly in the quantitative analysis is seen on the graph on the far right, clearly suggesting that the actually gliosis was reduced by oral administration of pimafibrate 5 days after the retinal injury, retinal reperfusion injury. As you can see here, this is without the black bar, without ischemia reperfusion stimulus. With ischemia reperfusion without pimafibrate, the white bar, the gray one, is in the presence of pimafibrate. You can see the degeneration and death of the cells is clearly reduced on the picture on the far right. Now, at the bottom are representative analysis that show the number of retinal-induced, ischemia reperfusion-induced inflammatory cells. These are inflammatory cells, as you can see here, particularly in those animals that are they underwent ischemia reperfusion without pimafibrate. These two central pictures are stained with markers of microglial, particularly activation. And as you can see here, clearly these numbers of activated cells was reduced by the administration of pimafibrate. Those are the two pictures on the far right. So clearly, the use of pimafibrate suppresses actually retinal degeneration, along with decreasing retinal inflammation via a number of molecular regulatory pathways. So at the end of the day, these are animal models, but pimafibrate, a potent PPAR alpha activator, is truly a promising approach in preventing drugs or in preventing the lesion that are caused by the ischemia reperfusion model in the retina in these mice. Let me move on to capillaries of the retina. These are effective PPAR alpha agonists, specifically in this case is fenofibrate, on retinal capillaries. On the top picture, you see acellular capillary, so apoptotic cells that clearly are increased, as you can see from the quantitative analysis, in patients with diabetes. So there is a major suffering of endothelial cells that, of course, lead to leakage of the intravascular content. The administration of fenofibrate in these models with diabetes actually prevents reduce the number of acellular capillaries by square millimeters. On the bottom side, on the other hand, you see the pericyte ghosts, once again, pericytes that lost nuclei, so which means apoptotic pericytes greatly increased in patients with diabetes, once again, significantly decrease in patients with models with fenofibrate. So fenofibrate, in this case, a PPAR alpha agonist, protect pericytes and retinal capillaries from apoptosis, preventing, of course, the consequences, one of which being leakage on the intravascular content. Let me show you another very interesting way by which PPAR alpha activation can prevent formations and progression of diabetic retinopathy. We saw that pimafibrate was highly active in preventing severe inflammation and new vascularization. Apoptosis was prevented in retinal capillaries and pericytes by another PPAR alpha agonist, fenofibrate. Now I present you data on new vascularization. New vascularization, this is a central concept, because when we look at microangiopathy, whether we look at microvascular occlusion, retinal ischemia, and new vascularization, and we see that part of this mechanism is really played by the vascular endothelial growth factor, or we look at the other arm, microvascular leakage and breakdown of the blood-retinal barrier, apoptosis of retinal cells, for example, in both pathways, we find that VEGF plays a central role. Vascular endothelial growth factor. Keep in mind that actually this name. One key element to understand why the PPAR alpha agonists are so effective is to understand that PPAR alpha receptors are expressed on the endothelium of human vessels. The left picture shows you actually the endothelium of a human pancreatic cancer. The right-hand side is patients with prostate cancer. The staining, the greenish staining on the left and the yellowish staining on the right, highlight the presence of PPAR alpha receptors I would say, the endothelial cells. So no wonder PPAR alpha agonists have a direct effect on the retinal capillaries. Now let's go back to mouse model. This is a mouse. It's a cornea injected with VEGF, and VEGF, vascular endothelial growth factor, does what it's supposed to do. You see here new vascularization. What I'm going to show you is the same experiment, but performed on animal cornea of animal models, where different fibrates, gemfibrate, bezafibrate, fenofibrate, other experimental fibrates, were injected before using VEGF. And as you can see here, there is a remarkable prevention of neoangiogenesis in the animal, in the cornea of the animal, pre-treated with PPAR alpha agonist. And the decrease in neoangiogenesis is directly proportional to PPAR alpha activity. To that respect, I must mention one thing. Pimafibrate is way more potent PPAR alpha agonist than fenofibrate. To give you an idea, pimafibrate activates PPAR alpha receptor at the picomolar concentration. Fenofibrate does the same, activated PPAR alpha receptors at a micromolar concentration. So it's an order of magnitude completely different. So the effect of neoangiogenesis seems to be dependent on the strength of PPAR alpha activity. To give you an idea and specifically understand that the effect of neoangiogenesis is due to the interaction between PPAR alpha agonist, fenofibrate. We have the same data with pimafibrate and the receptor. Actually, it's interesting to show this experiment. Let's see the yellow line. The yellow line suggests what is the proliferation, neovascularization at increasing concentration of pimafibrate progressively decreases. But this effect disappears if we treat this animal with the PPAR alpha antagonist that blocks PPAR alpha receptors. And as you can see here, of course, increasing concentration of fenofibrate does not inhibit proliferation because the receptors are blocked, which actually means that fenofibrate exert the protective effect against neoangiogenesis through PPAR alpha receptors. Another model, it's an animal model with where PPAR alpha is expressed, or there is a knockout PPAR alpha animal model. So in the wild type, as you can see here, injection of VEGF results in new vascularization. With fenofibrate, this new vascularization is prevented. But interestingly enough, in animals without the PPAR alpha knockout, the pre-administration or use of fenofibrate on the animal model does not prevent new vascularization. Once again, suggesting that the effect of PPAR alpha agonist, in this case fenofibrate, same data for pimafibrate, works through activation of PPAR alpha receptors. Now, a direct effect, so on PPAR alpha agonist on retinal inflammation and angiogenesis is highly likely, and of course prevents progression of retinopathy. In a mouse model, fenofibrate, we have the same data with pimafibrate, blocked vascular permeability, decreased vascular permeability by having a significant impact on inflammation through an increase in MCP1 or effect against MCP1 and ICA1 and leukostasis. So the inflammatory processes are blunted by the use of PPAR alpha activation, and thereby leakage and vascular permeability is restored or ameliorated, actually improved. In the model of oxygen-induced retinopathy, inducing ischemia, it's like the ischemia reperfusion model. Death of pericyte and endothelial cells. I showed you the picture where fenofibrate prevented actually acellular endothelial cells and pericytes when it was actually in models that had PPAR alpha agonist pre-medication. Well, death of retinal cells contribute to the dysfunction in the retina and the actually ischemia-induced retinopathy. VEGF is crucial for the proliferative changes in diabetic retinopathy, and fenofibrates, by preventing ischemia, blocks actually in a PPAR-dependent fashion the VEGF new vascularization. So these are all very interesting models. So clearly, this is evidence that PPAR alpha agonist prevents at several steps initiation and progression of diabetic retinopathy, working on leakage, inflammation, and new angiogenesis. What is the clinical evidence? Well, we have data from trials. FIELD is a trial in patients with type 2 diabetes, almost 14,000 patients. The trial was published in 2005. Patients were treated either with placebo or treated with fenofibrate 200 milligrams, follow-up of 5 years. As you can see here, when they look overall at retinopathy and the parameter or need for laser therapy as a sign for progressing retinopathy, in those on fenofibrate, there was a significant 31% reduction in the progression of retinopathy. This is overall. When we look at macular edema, that was decreased by 31%. The other type of retinopathy, proliferative retinopathy, 30%. In patients with pre-existing retinopathy, when they were enrolled in FIELD, that decrease was an amazing 39%. Now, it's broad-based effect because it involves all kinds of retinopathy, macular edema and proliferative retinopathy. Is achieved rapidly because if you see when the two curves diverge, it's 8 months after the initiation of the study. It's in addition and independent of a significantly good blood pressure and glucose control, and most importantly, it's completely independent of the lipid phenotype, which is an interesting observation. Field had an ophthalmology sub-study, which involved roughly 1,000 patients when they looked more in detail about the progression of diabetic retinopathy using the early treatment diabetic retinopathy study criteria. And as you can see here, those who had by far the greatest benefit, as suggested in the previous slide, were patients in field with pre-existing retinopathy with 79% relative risk reduction, absolute risk reduction 11%. NNT, those with pre-existing retinopathy, 17 against 90 without prior eye disease. So a very small or cost-effective approach, small number of patients need to be treated to prevent a laser treatment in patients with diabetes with fenofibrate. The clinical benefit on retinopathy, even in the field ophthalmology sub-study, were seen independently of the lipid phenotype, no matter whether patients had high triglyceride, normal triglyceride, high cholesterol, low HDL, or high HDL. The ACCORD-I was the second study confirming the effect of PPAR alpha agonist, again, in this case, fenofibrate. In this case, was fenofibrate in combination with simvastatin as compared to simvastatin alone. That was the control group. ACCORD, actually, I was a pre-specified sub-study. It was part of the ACCORD study. ACCORD study looked at patients with diabetes that underwent either an intensive glucose control as compared to a standard glucose control, dyslipidemia, an approach for dyslipidemia, which include fenofibrate simvastatin as compared to simvastatin alone, or an intensive blood pressure lowering approach as compared to a standard approach. With no surprise, an intensive glucose lowering approach led to a 37% decrease in the relative risk of progression of retinopathy. On the other hand, the intensive glucose lowering arm had to be stopped early due to an increased cardiovascular mortality and a significant number of hypoglycemic events. Patients on fenofibrate and simvastatin had a 40% relative risk reduction in the diabetic progression of diabetic retinopathy, equal to that seen in the intensive glucose control without any significant side effects. Intensive blood pressure control had no effect as compared to a more conventional standard approach. Even in the ACCORD-I study, the population that received by far the greatest benefit were those with prior retinopathy, where once again there was an amazing decrease in the need for laser therapy, and the NNT was 14. So a very small number of patients needed to be treated. And again, this was a slightly more sophisticated way of monitoring retinopathy progression than in the field trial. The beneficial effect in ACCORD was seen on top of well-controlled LDL. You see the numbers, well-controlled glycemia, an HbA1c around 7, and a well-controlled systolic blood pressure, and these are measured at the end of the study. Now, retinopathy is common, and we knew it, but in field, for example, 20% of patients with the 5-year diagnosis had already retinopathy. In ACCORD, patients had the 10-year on average diagnosis of diabetes, so a longer duration, and 50% had retinopathy. Now, interestingly enough, as I said, fenofibrate in both studies reduced progression of retinopathy by 35-40%, and that was equally seen in patients with and without the atherogenic dyslipidemia. It's nice to see, and I'm going towards the end, that these results on randomized controlled trial are also seen on real-life observation. This is a paper recently published, 2023, that screened originally more than 1.5 million patients with type 2 diabetes, enrolled between 2008 and 2018. They used a propensity-matched scoring system. They ended up to have 22,400 patients with statin and fenofibrate, different statins and fenofibrate, and they matched them against 43,200 patients on statin monotherapy. What they observed is that in the overall population, there was a 12% decrease in progression of retinopathy, and this is a composite of diabetic retinopathy progression, as you see, including vitreous hemorrhage, vitrectomy, laser photocoagulation, and intravenous injection therapy. That was decreasing those on statin plus fenofibrate. Interestingly enough, and once again, those with prior retinopathy at the baseline, this is the solid line, receive a greater benefit than those without retinopathy, with the relative risk reduction of 17%, highly significant. So even the real life data confirms what you have seen. So the authors said that, of course, there was a significant effect on progression of retinopathy, slower progression of retinopathy seen in those on fenofibrate and statin as compared to a statin monotherapy. And even in this study, real life study, they showed that these positive effects on retinopathy were seen regardless of pre-existing cardiovascular disease, pre-existing metabolic abnormality, and independently of baseline triglyceride and HDL cholesterol levels. So the conclusion is that fenofibrate, in addition to a statin, was significantly beneficial in terms of lowering the risk of diabetic retinopathy progression in patients with type 2 diabetes and metabolic syndrome in a real life setting. So no wonder that the guidelines, and here we're focusing on the IDF, the International Diabetic Federation guideline, suggest that fenofibrate reduces the need for focal laser therapy, significantly lower the risk of progression of retinopathy. They mention inflammation and angiogenesis. Remember what I showed you in animal models. Pimafibrate, a strong, very potent PPAR alpha agonist, and fenofibrate, they both had an impact on inflammation and neovascularization. This is mentioned by the IDF guideline, and the recommendation is clear. Fenofibrate treatment in this case is strongly recommended for diabetic retinopathy cases. Now, if we look at Australia, the general practice guidelines, of course, recognize that both in field and accord there was a significant benefit by the use of fenofibrate in terms of the need for laser surgery. They even mentioned beneficial effect on neuropathy and nephropathy complication. The TGA guidelines had approved the use of fenofibrate in Australia for the treatment of diabetic retinopathy, and its use in patients with diabetes with evidence of retinopathy should be considered. And the benefits are independent of dyslipidemia. Right now, there are more than 20 countries worldwide where the use of fenofibrate is approved in patients with diabetes to decrease the progression of diabetic retinopathy independently of their lipid profile. So just to conclude, diabetic retinopathy is a major global health problem, and considering the sharp increase in new cases of diabetes will become even more so in the near future, can lead to vision loss and blindness. Glucose control and blood pressure control, particularly glucose control, is crucial to reduce diabetic retinopathy progression. Progression of diabetic retinopathy is clinically relevant, and the multifactorial approach is a must. It's a mainstay to reduce the progression of diabetic retinopathy. I showed you in the STENO2 trial in patients with type 2 diabetes that a multifactorial approach still leave patients with a clinically relevant progression of diabetic retinopathy, 51%. So we can call it residual microvascular risk. Now, the endothelial dysfunction, ischemia, inflammation, neovascularization, they all play are pathophysiological mechanisms that are key in diabetic retinopathy progression. I showed you animal models and human, progressing from non-diabetic, non-proliferative retinopathy to proliferative retinopathy. Now, PPAR alpha agonist, pimafibrate, stronger than fenofibrate. On the other hand, both decrease, we have data that are associated with the decreased inflammation, reduced leakage, prevention of cell apoptosis, both endothelial cells in the capillaries of retina and pericytes, and reduced VEGF-mediated neovascularization in animal models of diabetic retinopathy. In patients with diabetes, so we move from animal model to human data, field and accord study show that fenofibrate remarkably reduce the need for laser therapy, suggesting reduced progression of diabetic retinopathy in patients with and without dyslipidemia. In people with existing retinopathy, well, that is the group that received by far the greatest benefit, NNT 9, field 14 in accord. So PPAR alpha activation is, and PPAR alpha agonist are an extremely cost-effective approach in patients with pre-existing diabetic retinopathy. Initial evidence for real-life data, one of the last slides I showed you, real-life data, fenofibrate on top of a statin clearly showed a benefit in terms of diabetic retinopathy progression, and fenofibrate was the fibrate used. So that's real-life data. So guidelines, IDF, Australian guidelines from other countries recommend the use of fenofibrate for diabetic retinopathy in our clinical practice, regardless of the lipid profile. And with that, I thank you very much for your attention, and I'm available for any question you may have. Thank you very much.
Thank you very much, Alberto. I think it was a very comprehensive overview of data, both from experimental and clinical trials, and also from real-world evidence. And I think it's a field that has been massively expanding over the past few years. I've received a series of questions. We will not be able to address all of them, but I will start with an obvious one. Do you see the decrease of residual risk of diabetic retinopathy progression by both PPAR alpha agonism and SPARM alpha modulators as a class effect or even a superclass?
I think so. I think we have the evidence. That evidence comes from animal models where the two main PPAR alpha agonists that have been tested, I'm talking about the pimafibrate and fenofibrate, did impact on a number of key steps. Inflammation, I showed you new vascularization, cellular apoptosis. So I believe it's a class effect. Let me point out one interesting thing. In terms of macrovascular complication, it's highly debated that being a strong PPAR alpha agonist might be more beneficial than a milder PPAR alpha agonist. In terms of microvascular complication, the evidence is that the benefits are strongly related. I showed you one slide with the PPAR alpha agonist activity. Pimafibrate, again, it's an order of difference in terms of more potency or more potent activation as compared to pimafibrate. So my answer is yes, it's a class effect, and the effect on microvascular disease is clearly dependent on the potency of PPAR alpha agonist activity.
So thank you, because you answer another question just in the same answer. The question one, do you see that the benefit would be even greater if you have a more selective, more potent agonist, which is obviously
I think so.
I think I can
confirm,
as you say.
Yeah, that is my answer is yes.
Especially because it is lipid independent.
It's lipid independent.
Now,
that's
there's
a key
another
point. Yeah.
Exactly. There is another question still in that field. Would you expect that the benefit of PPAR alpha or SPARM alpha agonism on DRP would be additional to that of anti-VEGF because of their pleiotropic actions?
I think so. I think they're complementary, actually. And they approaches a key step, which is the, of course, vascular endothelial growth factor effect on new angiogenesis. But as I mentioned, the PPAR alpha agonist or SPARM agonist, they do have an impact on different key mechanisms, including inflammation, microglial activation, and leakage. So I think they're complementary. And as you can imagine, the cost and the approach is very different. Anti-VEGF is invasive. It's injections that are quite expensive. Whereas SPARM agonists are orally administered and widely available. My answer is, and my feeling is that they are complementary. You can start with a SPARM agonist at the initial state of diabetic retinopathy, where VEGF actually VEGF antagonists are not yet indicated. I guess they are complementary and they can use together at the later stages of disease. My feeling is that SPARM agonist and PPAR alpha agonist can be initiated at an earlier stage of diabetic retinopathy.
Surely. And thank you. Also a comment on the different course of the Kaplan-Meier, because in the real world Korean registry, quite a few more people has been on anti-VEGF than in the field and ACO, which are more older studies, so that may explain, I don't know if you think about that, the difference in the time of onset of the benefit, because in the real world there must have been many more patients already on anti-VEGF, and still we see quite a large benefit appearing a bit later.
That, Michel, is an extremely good point, because as you mentioned, probably the large majority of these people were in real life already treated with anti-VEGF. And that's one of the reasons why I think it's complementary, because despite that very active treatment, you still saw an effect, particularly in patients with pre-existing diabetic retinopathy. That's why I think, again, it's one piece of information, but it's real life information. It's a strong support of the data we had in Field and Accord, a randomized trial, and in animal models. So I think we have the whole chain of evidence, animal models, randomized trial, and now we start having real life observation that, as you suggested, add some information, because unlike Accord Field, these patients, of course, a significant number probably was already treated with anti-VEGF, and on top of that, phenofibrate showed a positive and significant further reduction in the progression of the retinopathy.
Thank you very much, Alberto. We have quite a few more questions, but we have to be strict with the timing of this webinar, so we will not address them now, but we'll be happy to answer your queries later. I think we learned a lot, and as I said, it was quite extensively covered. And I would like to really thank Professor Alberto for his holistic overview of those exciting data, especially the recent one on SPARM alpha modulators. And I think you have enjoyed this webinar as much as I have. So thank you again, Alberto. Thank you all of you who attended this webinar, and wherever you are in the world, bye-bye and have a nice day.